Welcome to the Deep Dive Ortho, the show dedicated to cutting through the noise in digital health and delivering the clinical insights that truly matter to you. And today, we're focusing on something that sits at the very heart of what we all do. I mean, in our field, whether you're facing a major trauma activation, assessing a complex orthopedic injury, or managing a patient who's deteriorating in critical care. Well, our world is defined by rapid, high-stakes decision-making. And for decades, we've relied on scoring systems developed primarily in the last century. These are tools based on static vital signs that, let's be honest, often lead us down paths of imperfect triage. The critical challenge we all face is twofold. We have under triage, where a critically ill patient is missed and definitive care is delayed, which can, of course, cost a life. But then there's the other side of the coin, over triage, where precious high-level resources like major trauma theater time or ITU beds are unnecessarily strained by patients with lower acuity. The conventional tools, well, they use limited, linear data, and they've demonstrably got limited accuracy. It's a problem that perpetuates these risks across the globe. So today we are undertaking a deep dive into the emerging body of evidence showing how artificial intelligence, specifically machine learning models, are not just performing slightly better, they're fundamentally redefining the limits of predictive accuracy in pre-hospital and A&E triage. Our mission is to understand exactly how this paradigm shift impacts resource allocation, workflow, and patient outcomes, particularly in your daily practice within trauma and orthopedics. And guiding us through this rapidly evolving landscape is our expert guest. His work focuses on synthesizing these cutting-edge findings and translating them into tangible, real-world clinical applications. Welcome.
Thank you. It's a real pleasure to be here. I think the data we're looking at today signals a step change in acute care. For years, we've tolerated a certain level of inaccuracy in triage simply because we didn't have better tools. Now that the evidence is here, we really must seriously consider the implications. The performance metrics we're seeing demand that we rethink risk stratification entirely.
Let's start there then. The scale of that inadequacy. When we talk about these conventional triage tools, the revised trauma score, the ESI, the things we use every single day, why do they consistently fall short when faced with the complexity of real human physiology in distress?
Well, the core issue is really the structure of the traditional scores. They're inherently static and linear. They might take, 5 or 6 variables: heart rate, blood pressure, respiratory rate, GCS,
Yeah.
and then assign a weighted point total. They treat the input data as discrete, often binary entities.
Right, it's a yes or no question. Is the patient hypotensive, yes or no?
Exactly. Is the respiratory rate above a certain threshold? Yes or no? But human physiology under acute stress is anything but linear. A patient in shock doesn't transition smoothly from mild to severe. The compensatory mechanisms are incredibly complex and dynamic. The simple static scores just cannot capture those nonlinear temporal relationships. So consequently, when these tools have limited accuracy, often an area under the curve, or AUC, of around 0.6 to 0.7, you inevitably have a significant rate of under-triage.
And that missed patient gets delayed definitive care, leading to worse outcomes.
Precisely. And conversely, the high rates of over-triage waste resources. This is a global problem. It affects wealthy nations dealing with constant A&E crowding, and it certainly affects low- and middle-income countries, where resources are already so severely limited and where, tragically, 90% of injury-related fatalities occur.
Okay, let's unpack this shift in methodology then. If the traditional scores are so insufficient, what is the core finding regarding machine learning in this space? Is the improvement marginal, or are we truly looking at a complete reevaluation of how we assess acuity?
The core finding is that the improvement is profound. It's not marginal in the slightest. It really does represent a paradigm shift. ML models consistently and significantly surpass established guideline-based tools and traditional early warning scores across the entire spectrum of time-critical emergency conditions. They can handle that nonlinearity that just stumped the old static scores.
Let's focus immediately on the trauma setting. For our orthopedic and trauma specialists listening, what kind of performance are we seeing when these advanced algorithms predict severe trauma?
Right. If we look specifically at predicting the need for major trauma center intervention, the studies using sophisticated models, specifically things like gradient boosting and various types of neural networks, are showing consistent, high-level predictive capability. We're seeing area under the curve values generally ranging between 0.75 and 0.93.
Which is already a significant jump.
It is. But the critical metric for safety, I think, is the reduction in missed patients. These algorithms demonstrated the ability to reduce under triage to less than 10%.
Less than 10%.
Yes.
Now, that is a clinically meaningful and massive improvement over conventional standards. When you can consistently get critical patients to the right place first time, you save lives. And this performance advantage isn't exclusive to trauma. If you consider critical care prediction in a general A&E setting, one particular deep learning model was designed to predict the likelihood of needing an ITU admission. It achieved an impressive AUC of 0.908.
Wow.
And what's particularly compelling, especially for pediatric clinicians, is that this specific model outperformed the established Pediatric Early Warning Score, or PEWS, as well as standard conventional triage systems in identifying which children required the highest level of care.
That improvement in accuracy for critically ill children alone is huge. But what about when time is truly brain or time is limb? Thinking about stroke or severe respiratory issues, does AI maintain that edge?
It does, absolutely. Time-critical neurological triage is a perfect use case for this. Pre-hospital stroke algorithms, specifically designed for the rapid identification of acute ischemic stroke, and crucially for predicting large vessel occlusion, or LVO, which is the key decision point for where to take the patient.
Precisely. These algorithms have reached extremely high AUCs, above 0.98 for simple stroke identification. But more than that, models using ensemble methods like gradient boosting and XGBoost achieve 91% accuracy for LVO prediction.
91%.
Yes, and that is the crucial piece of information. Predicting LVO in the pre-hospital setting allows the ambulance crew to bypass the local hospital and go straight to a comprehensive stroke center for a thrombectomy. That immediate resource allocation decision is hugely impactful. We see similar performance in respiratory conditions too. Neural network and random forest models showed an AUC of 0.88 in pre-hospital acute respiratory distress syndrome, or ARDS, prediction. The machine is identifying patients at risk before the clinical picture is even fully overt.
Okay, so let's get into the why. You mentioned non-linearity, but what data features are these models leveraging that we as clinicians calculating the RTS in the trauma bay are simply missing? What's the secret ingredient here?
It really boils down to two things: feature engineering and, critically, data depth. Traditional scores are limited to those static snapshots, heart rate 120, BP 90 over 60. AI, on the other hand, can process and synthesize massive amounts of data, and most importantly, it can capture subtle temporal changes. It looks at the trend of the vital signs, the slope of the change, not just an isolated number.
So it's a trajectory that matters.
Exactly. It's leveraging information far beyond the static points. Physiological waveform data, for example. Subtle changes in simplified consciousness scales over minutes. And its ability to integrate incredibly diverse data inputs. This includes unstructured data, like the language used in the paramedics' notes, demographic information, multiple point-in-time vital signs. The algorithm is designed to find those subtle patterns and correlations, the physiological whispers, if you will, that are utterly invisible to a simple linear model, or, frankly, the human brain under acute stress.
Let's delve into one of the most remarkable findings you cited, the trauma mortality prediction study from South Korea. An AURC of 0.9974 is, well, it's staggering. When we talk about prognostication in trauma, there's always this concept of unavoidable mortality. How does a near-perfect prediction challenge our definition of unavoidable?
That study, it used a retrospective cohort with a massive nationwide data set of over 6.5 million A&E visits.
Yeah.
It achieved a level of discrimination that is genuinely revolutionary, an AOC of 0.9974, and for those who aren't familiar, 1.0 is perfect prediction. It suggests that in that specific data set, the factors determining mortality in the emergency department were almost entirely identifiable by the machine.
So it almost removes the idea of chance.
In a way, yes. It challenges the concept of unavoidable mortality, because it implies that if you could input all the available data, the outcome is highly predictable. It suggests that any failure we currently experience in triaging or predicting mortality is fundamentally a failure of data processing and timely intervention, not a failure of physiology being inherently unknowable. If the model can predict it with that accuracy, it means the physiological tipping point was apparent long before the clinical deterioration became irreversible.
That really does demand attention. So what specific features did this extraordinarily accurate model identify as the key predictors of mortality in the A&E? This tells us what truly matters in those crucial first minutes.
Precisely. The feature importance analysis revealed a clear hierarchy of risk. Predictably, age and unresponsiveness, specifically measured via the AVPU scale, so unresponsive or coma, were the top two mortality predictors. They were followed closely by oxygen saturation.
All things we'd expect.
Yes, but here is the critical connection for our orthopedic and trauma audience. The AI identified specific ICD-10 codes related to musculoskeletal injury as highly significant predictors of mortality. Specifically, multiple rib fractures and lumbar vertebra fracture were flagged. Now, these aren't just isolated bony injuries, they are surrogates for high-energy mechanisms, for significant axial loading, for severe chest wall instability that leads to respiratory compromise, and for underlying visceral or spinal cord injuries. The AI pulls out these specific injury patterns, which mandate massive resource demands and carry high mortality risk, from a sea of data. It confirms their critical importance far beyond just the static vital signs. It's identifying the silent drivers of death.
That focus on high-risk injuries takes us perfectly into the clinical area most relevant to trauma management: catastrophic hemorrhage. Predicting the need for a massive blood transfusion in MBT is one of the most resource-intensive, high-stakes decisions we make. Traditional scores, like the ABC score, are notoriously imperfect, yet we base our protocols on them. What does the evidence show about AI's ability to predict MBT?
The prediction of massive blood transfusion is arguably the clearest example of ML providing immediate superior clinical utility. Activating an MBT protocol requires mobilizing highly specialized hospital resources, often diverting staff and blood products away from other patients. Getting this prediction right is crucial, both for the patient and for system efficiency. A very comprehensive study directly compared multiple ML models, things like logistic regression, random forest, and XGBoost, against the two established clinical scores: the assessment of blood consumption, or ABC, and the revised assessment of bleeding and transfusion, the REBT. The outcome was, while it was unambiguous, the ML models were significantly better.
Let's talk numbers here, because this is where the conventional scores really seem to struggle.
Indeed, all the ML models attained a very solid AUC, ranging from 0.75 to 0.83. This represents good to very good discriminatory capability. Now, you look at the traditional scores, the ABC score, which is widely taught and used, achieved an AUC of only 0.52.
An AUC of 0.52, that is barely better than flipping a coin in the trauma day. It suggests the established score is providing almost negligible predictive power.
Precisely. It's essentially non-discriminatory in isolation.
Hmm.
The RBBT score was slightly better. It came in at an AUC of 0.64, but that's still substantially inferior to even the least complex of the ML approaches. This difference isn't just statistically significant. It has enormous clinical consequence.
And what does that performance gap mean in practical terms for the trauma team? Specifically, how does it address the crucial problem of under-triage in hemorrhage?
The major clinical benefit is a dramatically increased sensitivity.
Right.
Sensitivity is the measure of how many patients who truly need MBT are correctly identified by the score. The EMM models consistently showed much higher sensitivity, ranging from 0.55 up to 0.83. You contrast this with the ABC score, which achieved only 0.36 sensitivity.
36%.
Yes, so when you use the ABC score, you're missing 2/3 of the patients who need a life-saving massive transfusion. When a trauma surgeon is dealing with an open pelvic fracture or a complex, high-energy long bone injury combined with physiological instability, well, missing that MBT activation window has disastrous consequences. These ML models fundamentally improve patient safety by ensuring fewer patients who desperately need those resources are missed.
This raises a critical point about implementation versus just raw performance. We often assume the most complex model, say a deep neural network, must perform the best. But if a model is a black box, if the clinician can't understand the rationale behind a life or death recommendation, they won't trust it, they won't use it. What did the research conclude about this trade-off between accuracy and interpretability?
That trade-off. It's the great implementation lesson here. While a complex neural network did perform very well when it achieved an AUC of 0.81, the study ultimately recommended a complete, simple logistic regression model.
So the simpler model.
Right. The reason was straightforward. The logistic regression's performance was comparable. In fact, it achieved the highest AUC at 0.83, but it offered vastly superior interpretability. Transparency. Clinicians are inherently more comfortable with linear regression models because you can look at the output weights and confirm that, for example, a higher heart rate or a lower systolic pressure contributes positively to the MBT prediction score. This aligns perfectly with decades of clinical intuition, and that fosters trust. The best model for implementation isn't always the one with the highest technical score, but the one that performs excellently while maintaining clinician confidence.
That makes perfect sense. Trust is the currency of clinical AI adoption. Did they identify any specific data points that were surprisingly useful or maybe confirmed our suspicions?
Yes. The sensitivity analysis was fascinating. It showed that incorporating readily available imaging information, specifically a positive pelvis X-ray, further improved the predictive performance. For the orthopedic trauma audience, this is key. A machine learning model that integrates physiological data with a simple, rapid X-ray finding, like a specific fracture pattern, can elevate prediction beyond what either variable could achieve alone. It really demonstrates the power of multimodal data synthesis.
Let's shift to geography. You mentioned the global disparity in trauma care. The vast majority of trauma fatalities occur in LMICs, where resources are so critically constrained. Do these highly accurate, data-hungry models actually translate effectively to low-resource settings? Or do they rely too heavily on advanced monitoring infrastructure you'd only find in high-income countries?
This is perhaps the most socially compelling application of AI. The evidence suggests that ML offers some of its most dramatic improvements in low-resource environments, precisely because the baseline scores used there are so poor. We have very compelling data from settings like rural Uganda. ML is applied to trauma triage and compared directly against the Kampala Trauma Score, or KTS, which is the standard benchmark used there. The difference was astonishing. Random forest and gradient boosting models achieved AUC-ROC values of 0.91.
0.91 is excellent. What was the performance of the established benchmark, the Kampala Trauma Score?
The KTS achieved an AUC-ROC of only 0.62.
Wow.
That difference, 0.91 versus 0.62, is a radical improvement in predictive capability. It signals a complete failure of the old static system in that specific diverse population. A jump of nearly 30 points in the AUROC in a resource-constrained environment represents a massive potential to save lives, just by directing the few available resources, be it a ventilator or an operating theater, to the patient most likely to benefit immediately.
That is profound. It suggests that highly accurate triage doesn't necessarily require complex, continuous physiological monitoring. What limited data inputs were these ML models in Uganda using to achieve such high accuracy?
And that is the key for low-resource implementation. The ML models achieve this high discrimination using a remarkably limited set of injury information and basic demographic points. The most significant predictors identified by the algorithm were surprisingly simple: sex, hours to hospital presentation, and age.
Really? Just those basic points?
Yes. It's a powerful confirmation that advanced algorithms can take basic, consistently acquired data that are acquirable even with minimal infrastructure, and synthesize highly effective risk predictions. This capability provides a critical foundation for improved resource allocation in places where complex scoring systems fail completely. And we see this trend in specific high-stakes injuries as well. Deep learning models have shown high accuracy in predicting outcomes after traumatic brain injury in LMICs, achieving an AUROC of 0.941. Considering neurosurgical resources are perhaps the most restricted service in these regions, having predictive certainty at that level provides crucial ethical decision support for rationing limited intensive care and surgical slots.
So far, our discussion has really centered on improving the patient's immediate clinical trajectory, but AI is also proving its worth at a systemic level, addressing the chronic operational problem of emergency department crowding. How is AI moving from just acute triage to driving system-wide efficiency?
That shift is fundamental to adoption. An A&E cannot function if it's permanently choked by crowding. Crowding isn't just an administrative headache, it's a clinical danger. It's demonstrably associated with adverse patient outcomes, including increased mortality due to delayed care. So the ability to forecast this crowding with high accuracy is the first proactive step. Recent research has shown significant success using advanced deep learning models to forecast pediatric ED overcrowding. But the crucial element here is that the forecasting system was integrated with the machine learning operations, or MLOps, architecture.
MLOps, that's a term our audience may not be immediately familiar with. For the practicing clinician, how should they understand MLOps, and why is that architecture so essential for maintaining performance in medicine?
MLOps is essentially the engineering framework for continuously deploying and managing AI models in production. Think of it like this. An academic study gives you a snapshot, a model that works perfectly for data collected between, say, 2018 and 2020. But in medicine, the underlying reality changes constantly. We have new treatment protocols, population demographic shift, and of course, global events like the COVID-19 pandemic create massive data drift.
The model becomes outdated.
Exactly. MLOps facilitates the continuous automated monitoring and retraining of the model. It recognizes when the model's prediction accuracy starts to drop due to this data drift, and it automatically updates it with fresh, real-world data. It ensures the predictive performance remains high. It's the difference between a static photograph and a constantly updating live video feed.
And what was the measurable efficiency dividend when this MLOps-backed forecasting was deployed for A&E staffing?
The results were quite substantial. The accuracy of the forecast, measured by the R-squared score, improved significantly, rising from a median of 44% to 60%. And crucially, this enhanced accuracy translated directly into superior shift optimization. The system allowed for dynamic adjustment of physician staffing. It increased physician allocation by up to 30.4% during peak hours, late afternoon, and early evening, precisely when historical staffing models often fail to cope.
So getting the right people in the right place at the right time.
Precisely. This optimization successfully reduced the patient-to-physician ratio by over 4 patients per shift. And the important takeaway is that this was achieved without increasing the overall staff headcount. It's not about hiring more people. It's about deploying your existing limited resources far more intelligently.
That makes a compelling business case as much as a clinical one. Let's move this focus directly to the orthopedic clinician's workflow. The trauma unit relied heavily on rapid imaging interpretation. What is AI doing right now to directly support diagnostics?
For the clinician, particularly in orthopedics and trauma, AI is providing an exceptional diagnostic safety net via convolutional neural networks, or CNNs. These networks are designed specifically for image recognition. We see high performance across the board. CNNs attained over 90% sensitivity and specificity for identifying solid organ abdominal trauma on CT scans, helping the trauma surgeon rapidly identify liver or spleen injuries. But specifically for orthopedics, the performance on plain radiographs is phenomenal. Models achieved up to 97% accuracy in diagnosing distal radius fractures on X-rays. Furthermore, models demonstrated 98% sensitivity for identifying occult or subtle hip fractures on pelvic X-rays.
98% sensitivity for a hip fracture on a pelvic film. I mean, every orthopedic surgeon listening knows the immense clinical and medical legal ramifications of a missed hip fracture, especially in a busy A&E on a Friday night. How does that level of accuracy impact surgical logistics and patient safety?
It provides 2 immense benefits. First, it's an unparalleled safety net against human error, particularly when films are being interpreted by junior staff under duress. If the AI flags a 98% likelihood of a hip fracture, it mandates immediate senior review. This helps ensure that crucial time-dependent surgery, getting that patient to theater within the guideline window, is not delayed.
And the second benefit?
Secondly, it allows for smart workflow prioritization. If an A&E has 50 radiographs waiting for review, the AI can prioritize the PCSQ. It immediately highlights the films with a 97% certainty of a distal radius fracture or 98% certainty of a hip fracture, ensuring the most urgent surgical cases reach the consultant radiologist and the surgical team first. And the technology isn't just saying fracture, yes, no. Advanced models can precisely pinpoint the lesion. One study showed 95.9% precision in localizing the hip fracture. This hybrid approach, the clinician managing the case and the AI localizing the injury, fundamentally improves the interpreter's overall sensitivity and helps avoid those catastrophic misdiagnoses.
Before we transition to the implementation hurdles, let's briefly revisit the critical illness trajectory once the patient is admitted. We noted the research gap in pre-hospital sepsis models, but what capabilities do we see once that high-risk trauma patient is in the ITU?
Well, once the patient is admitted to the intensive care unit, the data stream becomes far richer. You have continuous vital signs, lab results, medications. This allows predictive capability to sharpen dramatically. A model using extreme gradient boosting, or XGBoost, was developed specifically to predict sepsis onset among trauma ICU patients. It achieved a strong AUROC of 0.88 within a tight 4-hour prediction window.
A 4-hour window?
Yes, but more critically for clinical action, that model was able to predict 91% of sepsis events in the subsequent 6 hours. This provides a crucial early warning window, a full 6 hours, which is often enough time to initiate aggressive interventions, fluid resuscitation antibiotics, potentially mitigating the development of septic shock.
Professor, the data we've reviewed is extraordinary. Near-perfect AUROCs, 98% diagnostic sensitivity. They paint a picture of a revolution in acute care. Yet, most of us in busy trauma centers still rely on clinical gestalt supported by those decades-old linear scores. So what is keeping these powerful models from moving out of the research paper and into standard clinical practice?
That gap between the prototype and genuine scalable practice is the defining challenge of the next 5 years. Without question. Despite the impressive technical metrics, most of these compelling studies remain retrospective. They're limited by narrow patient populations, and they often draw from single-center data. This leads to a severe lack of prospective, multi-center validation, which is absolutely necessary to ensure the model generalizes robustly across different hospitals and different patient demographics.
And beyond the validation.
Beyond that, we lack evidence on real-world deployment. specifically user acceptability and, crucially, the measurable impact on patient-centered outcomes, not just prediction scores. And workflow integration is perhaps the most significant logistical hurdle. An AI system, no matter how accurate, that requires 7 extra clicks or slows down the trauma team's processing time by 30 seconds is a system that will be ignored or actively disabled by busy clinicians. It has to augment, not impede.
You've highlighted that a lack of trust can render even the most accurate model useless. This brings us back to interpretability. We saw in the MBT study that clinicians preferred the transparent model. For widespread medical adoption, we simply can't accept black boxes making high-risk decisions. How does the field use explainable AI or XAI to build this trust?
Transparency is the price of admission for clinical AI. Explainable AI is the discipline dedicated to making the decision-making process transparent, addressing the clinician's need to understand why a recommendation was made. Even when we use a highly complex neural network that performs better than the simpler models, XAI techniques can still provide that necessary window into the machine's reasoning. The most common techniques are things like S-shape, LIME, and GradCam.
And how do they work in practice?
They perform complex feature importance analysis. So, for example, in the ED mortality prediction models, XAI can explicitly generate a report for the clinician showing that the high mortality risk prediction was driven 60% by the patient's severe hypoxemia, 25% by their age, and 15% by that ICD-10 code for rib fractures.
So it shows it's working.
Exactly. It allows the trauma consultant to quickly validate the underlying reasoning against their own training and clinical intuition. This fosters trust and enables critical thinking rather than blind compliance.
The moment we start training these powerful models on vast data sets of real-world patient information, we have to confront the issue of inherent bias. How does algorithmic bias manifest in the acute care setting, and what are the dangers of models trained on homogeneous data?
Algorithmic bias is a critical safety issue. It occurs when a model, trained on historical data, learns and then compounds existing systemic inequities based on socioeconomic status, race, or gender, and inadvertently amplifies those disparities. The machine doesn't create the bias, it replicates the flaws present in the data we feed it.
And the risk is magnified by data homogeneity.
Absolutely. If a model for MBT prediction is trained primarily on a large trauma registry from a metropolitan area in a high-income country, it may learn patterns specific to that population. When that model is then deployed in a rural hospital or in a different country with different demographics or different pre-hospital care standards, it may significantly underperform. This failure to generalize means the AI will likely provide poor predictions for underrepresented patient populations, thereby exacerbating existing health disparities.
And beyond the technical problem of data, there are the profound medical, legal, and ethical questions. If an AI system recommends against activating the massive transfusion protocol, the clinician follows that advice, but the patient deteriorates. Who holds the responsibility?
This medical legal accountability issue is largely unresolved, and it creates a very difficult gray area. If an AI recommendation conflicts with the clinical judgment of the attending physician, and the clinician chooses to follow the machine, and the patient suffers harm, the liability is unclear.
It's a diffusion of responsibility.
It is. Is it the manufacturer who designed the algorithm, the clinician who chose to follow it, or the institution that implemented it? Currently, that responsibility is diffused, which places an unfair burden on the healthcare professional operating in a high-pressure environment.
And what about informed consent? In a trauma call or an acute stroke, that seems almost impossible to acquire for an AI-assisted decision.
It's extremely challenging. The patient may be unconscious or otherwise unable to provide explicit informed consent. In these time-critical scenarios, the responsibility often defaults entirely to the healthcare professional operating under implied consent due to necessity. It's an ethical challenge that necessitates very careful policy development.
So how do we mitigate these risks and transition safely from these promising prototypes to reliable, ethical, global standards of care?
Mitigation requires multifaceted action focused on data and deployment. First, model robustness requires diversity. Data science teams must include clinicians and professionals from diverse backgrounds to identify potential biases early on. Second, we must address the data homogeneity problem through collaboration. Multi-center data sharing is essential for building truly robust and generalizable models, and we must move toward collaborative methods like federated learning.
Could you elaborate on federated learning? It seems to be the key technical solution to the privacy issue.
Certainly. Federated learning is a decentralized approach to training AI models that addresses the need for broad data without violating patient privacy laws, like GDPR. Instead of sending all the raw patient data from 10 hospitals to one central server in federated learning, the machine learning model itself is sent out to the 10 hospitals.
I see. So the data never leaves the hospital.
Precisely. The model is trained locally on the raw data within the hospital's secure server, and only the updated parameters of the model, the learning results, are sent back to the central server. The central server then aggregates the learning from all 10 sites to create a more robust collective model. It's essential for achieving the breadth of data we need for generalizability without compromising patient confidentiality.
This has been an incredibly detailed exploration, and the evidence is overwhelming. We've established that machine learning models are not just a fractional improvement. They represent a fundamental leap in predictive accuracy across trauma, critical care, and specific orthopedic diagnostics. They reliably reduce under-triage, which is a critical safety win, and are already proving powerful for operational optimization, streamlining staffing, mitigating A&E crowding, and prioritizing surgical cases.
Indeed. We have firmly moved past the if of AI application in acute care. The discussion now must center entirely on the how and the when of safe, ethical, and scalable deployment. The evidence shows AI's immediate potential to transition from simple prognostic tools to genuine real-time decision support systems. For orthopedic and trauma specialists, the ability to predict massive transfusion needs with high sensitivity and achieve near-perfect diagnostic accuracy for critical fractures. These are changes that profoundly impact patient outcomes and resource preparedness.
I think the most significant message for our audience is that realizing AI's full potential hinges not just on chasing that final minuscule increase in the AUR's C-score, but on prioritizing the ethical, transparent, and user-friendly deployment of these systems. They must truly augment clinical expertise, ensuring clinician trust and seamless workflow integration. So here is our provocative thought for you to take away. Considering that stark performance gap, an AUC of 0.52 for the ABC score versus 0.83 for a simple ML model, or 0.62 for the Kampala trauma score versus 0.91 for a rural Uganda ML model, how quickly can we, as senior medical professionals, integrate the necessary data governance and ethical frameworks like XAI and federated learning to make these demonstrably life-saving tools standard practice in every trauma bay, rather than just academic novelties? If you found this deep dive valuable, please take a moment to rate and share the show with your colleagues. Thank you for tuning in to the Deep Dive Ortho.
Thank you.
We'll catch you on the next Deep Dive.